The cardiac cycle is usually divided into two phases: systole, when ventricles contract, and diastole, when ventricles relax. However, the issue is more complex. First of all, before the ventricular contraction, there is also an atrial contraction, since atria contract as well. Moreover, ventricular systole can be divided into two phases: isometric and isotonic phase. The difference lies in the type of myocardial contraction. If the myocardium contracts during isometric systole, but the blood volume contained in the ventricle doesn't change, the ventricular blood volume decreases as a consequence of the contraction. To be more specific, even the isotonic ventricular systole is internally divided, with the first slow phase followed by a second fast phase. Similarly, the diastole can be divided into the isometric and the isotonic phase. Obviously, the isotonic phase can be divided into a slow and a fast phase either. The cardiac cycle has 7 phases. Now, we're going to focus more on the single phases and events that occur inside them. Let's start from the atrial systole and let's have a look at its starting condition. This is going to be our system: atrium, ventricle, artery. The cardiac cycle is the same both on the right and on the left side. The pressure with which the cycle occurs changes, although the type of events is always the same. The upper part is going to be the atrium, the bottom part the ventricle. The protrusive part is going to be the artery that comes out from the ventricle, the pulmonary trunk on the right and the aorta on the left. These are going to be the atrioventricular valve and the arterial valve. Just before the atrial systole, we have the ventricle filled in part with blood. Later we'll understand why. The atrium that is full, the valve that is partially open, and the blood starts coming down. Actually, it is already down. But what happens during the atrial systole? The atrium contracts and presses the blood within the ventricle. So, the atrioventricular valve is completely open. The ventricle fills up. This is the end of the atrial systole that finishes with almost immediate release of atria. During the isovolumetric ventricular systole, we can see the contraction of the ventricular wall that starts to press on the ventricular blood without pushing it in the artery. At first, by compressing, the blood goes up and applies pressures on the atrioventricular valve that is then closed. The ventricular contraction increases the more and more, and the strength that the ventricle develops goes up. At this point, the strength applied to the arterial valve rises, but the arterial valve is still closed because the artery contains several centiliters of blood that, by pressing on the valve with all their weight, prevent the valve from opening. However, there will be a moment when the strength developed by the ventricle will level and exceed the strength of the blood contained in the artery. This is precisely the moment when the isotonic ventricular systole, also called ejection phase, begins. During the ejection phase, the blood, by going through the artery, opens the valve. The volume of the blood contained in the ventricle decreases because most of it will go in the artery. At the end of this phase, about 60% of the blood contained in the ventricle will have crossed the artery, and the rest will remain within the ventricle. However, sooner or later, the phase will end up, and so the strength developed by the ventricle will decrease, and the weight of the blood contained in the artery will start to burden on the semilunar valve and therefore closes it. This is when the diastole begins, that is to say, the ventricular release. During the diastole, the blood starts to flow from the atrium that fills up. At this stage, the atrioventricular valve is still closed because the ventricle is still partially contracted. For this reason, the ventricle applies a certain amount of pressure on the blood, which is not enough to push the blood in the artery, but is enough to keep the atrioventricular valve closed. the release continues, and thus the diastole is defined as isovolumetric because the blood volume contained in the ventricle doesn't change since the ventricle doesn't top up blood from the atrium. The next phase consists in the rapid isotonic diastole, or rapid filling of the ventricle. In this phase, the release of the wall has become so strong that it reduces the pressure applied by the blood on the ventricle, allowing the atrioventricular valve to open. In this way, the blood can start to flow from the atria and will quickly fill up the ventricle. At this point, the slow isotonic diastole, a release phase in which the atrioventricular volume increases, slowly begins. As the name suggests, the release of this phase is slow. So let's go back to the initial situation. The diastole is over, the atrium has received the last blood volumes from the systemic circuit, and it is ready to contract in a new atrial systole. By now, cardiac cycle seems to be a more complex phenomenon. Keep in mind volumes, pressures, and many further events, also electrical events that adjust the phenomenon. So we can inscribe this event in a graph that could help us understand the cardiac cycle. First of all, we have to consider the phases of the diastole and those of the systole. Here, the phases are related to the time spent. But let's focus now on pressures. The pressure of the left ventricle can be defined by this line. During the atrial systole, the ventricular pressure equals 0. During the isotonic contraction, it increases to a surge of 120 mmHg and then decreases to 0 during the diastole. The left ventricle works at high pressures, and for this reason, the graph is the most representative. The graph of the right ventricle is lower because the right ventricle works on pressures that go from 0 to 30, maximum 40 mmHg. Therefore, the figure will be similar, but the range is considerably lower. In parallel, we can see the minimum pressures on which the atrium works. The atrium reaches the first compression peak during the atrial systole, and the second during the isovolumetric contraction. This is because the ventricle, by compressing the inside blood, pushes on the atrioventricular valve that pushes on the atrial content, thus increasing in pressure. The pressure in the aorta follows a different line. First of all, we can note that the minimum pressure in the aorta equals 80 mmHg, and so the line never gets to 0. The pressure is constant due to the elasticity of the artery that pumps blood during the diastole too. During the isotonic contraction, the aortic pressure increases to 120 mmHg and then decreases to 80 during the diastole. But let's talk about volumes now. This is the graph of the volume in the ventricles. The blood volume in the ventricles increases during the isovolumetric contraction and then decreases first fast and then slowly during the isotonic contraction. During the isovolumetric diastole, the volumes remain constant, then increase quickly during the rapid isotonic diastole and slowly during the slow isotonic diastole. We can pinpoint that the ventricular volume varies between 130 ml and 50 ml, showing that the ventricle cannot be completely empty. As we have already said, only 60% of the blood in the ventricle at the moment of contraction will flow to the artery. Let's take a look at how these events are related to the electrical events that occur in the heart. Just before the atrial systole, there is the ECG P wave that we have already mentioned. The complex of QRS takes place between the atrial systole and the isovolumetric contraction. You can observe how the electrical event comes before the muscular event. In fact, the electrocardiographic repolarization occurs during the slow isotonic contraction. Eventually, as we can imagine, the cardiac events produce sounds, which can be defined as first heart sound, or S1, second heart sound, S2, in third heart sound S3. The first heart sound occurs at the beginning of the isovolumetric contraction, and it is due to the contraction of the ventricle that applies pressure on the blood inside and closes the atrioventricular valve. The blood beats on this valve, generating a long, low sound. Otherwise, the second heart sound happens at the outset of the isovolumetric diastole, when the blood, having lost the highest ventricular ejection, tends to return back to the arteries, and closing arterial valves generates a brief, higher sound. Given a slight desynchronization between the left and the right ventricle, the aortic valve will close before the pulmonary valve. In this way, the second heart sound will have both the aortic and the pulmonary component that may normally be slightly different from each other, but in some cases, they may space out, provoking a split of the second heart sound. Finally, the third heart sound is difficult to be heard in adults, but it can be easily heard in children. It is audible during the slow isotonic diastole due to the inflowing blood in the ventricle that, by pushing on the wall, produces a sound vibration. This sound vibration can be easily heard in children because their chest wall is thinner than that of the adults. For this reason, this sound can be spread, although it is less intense than the other ones. Thank you for watching. This video was created by School of Biomedical Sciences, Aorta. We hope you enjoyed it. If you're curious or have any doubt or question, please feel free to leave a comment below. If you want to find out more about us or want to support our project, click on the following link to visit our website.